Welcome to the Menopause Hour, your go-to source for empowering answers to your burning menopause questions, the ones you won't get from your OBGYN. Brought to you by Winona, menopause care made easy, and hosted by our experts, CMO Dr. Michael Green and Medical Director Dr. Kat Brown.
Hi, everyone, and welcome to another one of Winona's live Q&As. I'm so glad each and every one of you are here tonight. If you've never been to a Winona live Q&A before, we're so glad you're here, whether you're kind of finding us through the app, whether you're finding us through Facebook, whether we've sent you an email. You've made it here. That's awesome. We're so glad you're here. You can go ahead, and if you have a question for our doctors, we'll jump into it in a minute. But go ahead and start putting those questions down in the little chat box on the bottom right-hand corner of your screen. It can get kind of crazy in there, so we always like to encourage you to kind of get those questions in there early, and then we'll try to get to as many of them as we possibly can tonight. But just want to say again, we're so glad you're here. It says a lot about the fact that you're kind of jumping into, taking your menopause or perimenopause journey kind of by the reins, and you're here to ask questions. And we have some pretty amazing doctors that are part of the Winona team here tonight. I always love, we do these just about every other week. But I love getting to be on these every week, just because I feel like there's so many great answers that are questions that are answered and great insights. And we really get to kind of dive into just what is going on here. So I'm so glad you all are here tonight. And I'm going to let our doctors go ahead and introduce themselves, because I feel like there's always something special about kind of getting to hear, someone introduce themselves and tell you a little bit about what they've done. So I'll go ahead and kind of pass that over to Dr. Green, and then we'll get into your questions.
Hi, my name is Mike Green. I am the Chief Medical Officer of Winona. I am also a board certified OBGYN. I actually did a family practice residency first. And fell in love with women's health and decided that's really what I wanted to do. So I did a whole second residency so I could really specialize. I also like delivering babies, which was kind of fun. So, so I got to do that. But I've spent, my career, I finished residency in 1999, so it's been a while, really taking care of women, and it's been an absolute joy. And we started Winona, over 4 years ago now. It's been really exciting to see the growth and, just have the ability to touch so many women that otherwise don't have access to this important care, because there's just a lot of misinformation about HRT. And so that's one of the big reasons we do these Q&As, is to help clear up some of that misinformation that's out there. Somebody messaged me the other day saying that, well, ChatGPT said this. I'm like, well, Dr. ChatGPT is wrong, because ChatGPT gets its information on the internet, and there is so much crazy stuff on the internet that you can't expect ChatGPT to get it right. So you have real doctors, not bots and AI tonight. So please ask us questions in the chat. Anyway, I'm going to hand it over to Dr. Kat to introduce herself.
Thank you. Hi, I'm Dr. Kat Brown. I'm the medical director at Winona, and I'm also a board certified OBGYN. And so I came to Winona a little after Mike did, and really have made this a big commitment in my professional life, because I'm also going through it as well. But women's health has always been near and dear to my heart. And, it's always been my goal to try to make life better for any patient I touch. But the other thing that we have a really big focus on at Winona is education. We really think that it's very important for you to gain the knowledge you need to know about your own body, about what's going on, because knowledge is power. And the more you learn and the more you know what's happening in your body, the more you can advocate for yourself and get the help that you need and live your best life. And that's really the goal here, is just, living a good, vital life and really, living your best life. So anyway, that's us.
So we usually like to cover some little topic while we're waiting for the questions to roll in. Let's see, questions are rolling in, but keep typing away. I just want to talk real briefly about one of the sort of one symptom of the menopause transition that HRT just doesn't do a very good job of fixing, unfortunately, and that's abnormal bleeding. So it's pretty normal during the menopause transition for the periods to start becoming irregular, but usually they sort of start spacing out. And the idea is eventually they're going to stop altogether. But for most women, it's not like one day they're having normal periods every 28 days, and then boom, they stop and they never come back. It doesn't usually go that way. There's usually this period of time where they're coming inconsistently, and usually they sort of space out. HRT, for better or for worse, doesn't really affect the menstrual cycle. It's actually a good thing in some ways. People are often worried, oh, how am I going to know if I go through menopause and I want HRT? It's going to blunt that, or is this going to mess up my cycles? And it really doesn't. It's pretty neutral as far as your periods go. On average, people probably have less bleeding and a little bit lighter cycles on HRT, but it doesn't do a huge job of changing the cycles in that, for better or for worse. So what that means is if everything's kind of ticking along and all of a sudden you have some abnormal bleeding, it's not really necessarily because of the HRT. And so the answer is almost never, gee, I need to adjust my dose, because that's not really going to help. You really have to think in general, if you're having abnormal bleeding, particularly if you're having more frequent bleeding or spotting or bleeding in between your menstrual cycle, you really got to wonder if there's something underlying going on. And so you don't want to just sort of chalk it up, oh, it must be the HRT. No, that's maybe something that needs to be looked at to make sure there isn't something that needs to be treated. The exceptions are, it's pretty common to have some abnormal bleeding in the first 2 to 3 months of starting hormones, or when hormone doses are adjusted. So there is this sort of ramp up period where your body is kind of getting used to the hormones, and it can throw the periods off at the beginning. So if you're in the first month, 2 months, maybe even 3 months, and you're having some irregular bleeding, that's probably something you can write out and observe. Or if all of a sudden you change your dose, and now that triggers some abnormal bleeding, that's also something that can be observed. The other place where you can get abnormal bleeding from HRT is if you forget to use it. So if you abruptly stop the HRT, let's say you go on vacation, you forget your medicine, you go 3 or 4 days without taking it, that can trigger bleeding and cause some abnormal bleeding. So those would be the situations where you don't really need to necessarily worry about it, and you can sort of blame it on the medicine. But otherwise, it's something that probably needs an exam. It could be a polyp or an infection or fibroid or something else. And you don't want to just sort of ignore that and sort of blame it on the HRT and miss getting treated for something that's in there. So that's that's not a question that comes up very often on these. And it just happened to have come up a bunch in the last week or two. So it's like, well, maybe I ought to talk about this. So anyway, that's a little spiel on bleeding. And it looks like we got some questions. So let's hit your questions instead of mine.
Absolutely. It looks like we've got a good number of questions already in here. So let's jump right into them. Our first one is from Diana, and she's wondering, she says, HRT and breast cancer, is this a myth?
Not a myth, but a really blown out of proportion fear, I would say. So, and this is something that we're still fighting from the repercussions of how the media took results from a study done and released information, the Women's Health Initiative study back in the early 2000s. And it really caused this widespread panic and fear that hormones were really going to cause cancer in a lot of patients. But when you put it into perspective, and that's what Mike and I like to do a lot, thinking about the big picture, all the things that can kill you and things that can happen in your life. As a woman in midlife and after, you're much more likely to die of heart disease than you are to die of breast cancer. And so, there's things that can increase our risk and decrease our risk, but, there's so many different factors that can go into a woman's risk of developing breast cancer. Things like genetics, family history, things that you're exposed to in the environment, foods you eat, all kinds of things. And so taking one medication and the risk of that is not the sole factor that's increasing that risk for women. But what we do know is that taking estrogen-only hormone therapy actually can reduce your risk. Typically it's the progesterone component, which is needed when you have a uterus and you're taking hormone therapy, but taking that component can increase your risk slightly. But it's, when you look at the big picture, it's still a relatively low risk for most patients.
Absolutely. And our next question tonight comes from Chandra. And she is wondering, she says, I've been on the cream for 2 weeks and I haven't really felt like it's been getting any better yet with the hot flashes and my night sweats. Do you have any suggestions for me?
I mean, basically the bottom line is it's too soon. There is an adjustment period that your body is going through as you're taking a new medication. And the biggest thing that you can do as a patient to help your body to acclimate is to do all the other lifestyle things that you can do to help your body adjust to the changes. So this means optimizing your sleep, really working on your sleep hygiene, which I really shouldn't talk about right now because I was up all night delivering babies last night. But also hydration, super, super important. Making sure you drink enough water, especially in these summer months. If you're dehydrated, your body's ability to deal with hot flashes and these vasomotor symptoms is significantly decreased. You don't have the resilience and that internal thermostat to really keep in check. And so it doesn't matter how much medication you're taking. If you're not well hydrated, your body's not going to do well, and you're going to have more hot flashes and night sweats overall. And your nutrition too. So really focusing on avoiding foods that can be triggers for hot flashes, which ladies, all of you watching, alcohol is one of them. So if you're one of those women who likes a nightly glass of wine, might be time to kind of reevaluate that because that can also trigger hot flashes as well. So I would focus on that. Focus on doing all those other lifestyle things as your body is getting used to the medication. And the next thing you know it, you'll start to see the benefits starting to show.
Yeah, it can take 3 to 4 weeks just to get blood levels up when starting medicine. And then it takes a little while beyond that for the medicine to really take effect. So it's the answer nobody wants, but it's patience. And, it's the age old, I want patience and I want it now. So hang in there. Things are going to get better, but it does take time.
Absolutely. Well, speaking of patience, we have a question from Lisa. And Lisa says, how long do you have to be on HRT therapy?
I mean, the quick answer to this is that it's individualized for every patient. So this is a personal decision that you have to make in collaboration with your physician who's prescribing for you, or your provider if you're seeing a non-physician. But really, this is a personal decision. So with any medication, you have to look at the risks and benefits, and you look at your symptoms and what the medication is helping with. But also, we know there's so many other great benefits that estrogen therapy has on our overall health as women. So it can help to protect our bone health and help to prevent against osteoporotic fractures, help protect your heart. So a lot of women are taking HRT longer now than maybe they did 10 years ago. But this is something that you're going to reevaluate every time you kind of get a preventive medicine visit and you're getting your health checked, just to make sure that, this is still something you want to stay on. But it's a personal decision for each patient, I would say.
Absolutely. And our next question is progesterone not needed if a patient has had a hysterectomy?
True. For most cases. So the main purpose of the progesterone in our hormone therapy is to protect the uterine lining against overgrowth. So the way I like to describe this to patients is that estrogen is like this magic powerhouse hormone for women. It's our main hormone. It does so many positive things throughout every tissue in our body. But the one real negative thing it does is it makes that uterine lining, the endometrium, proliferate or grow and fluff up kind of like a shag carpet. And so the progesterone is needed to keep that in check so that those cells don't overgrow and you don't end up with hyperplasia, which can then lead to cancer of the uterus. And so it is needed if you still have your uterus.
This is a pet peeve of mine as well, because remember I said that ChatGPT gets it wrong because there's so much wrongness on the internet. This is a big one. It's a huge one. It's been going on for a very long time. I remember when I was in my family practice residency, one of my wife's friends gave me this book to read because doctors don't know what they're talking about. And it was talking about how progesterone is all you need and progesterone is a wonder drug. And by the way, at the end there was, and the only progesterone that actually works is the one that I personally sell, the author of the book. And so here's the address so you can order my progesterone. So, this book was this giant
red flag city there.
There you go. And the thing is, progesterone can help some symptoms, but it doesn't do anywhere near the good that estrogen does. And there's risk involved. As Kat was saying, it's the progesterone, not the estrogen, that increases the breast cancer risk. Progesterone in high doses can stimulate appetite and cause weight gain. So, it's not a freebie. And so it's estrogen that does the lion's share of the work. And that's really the hormone that's going to help you with all the things we've talked about. Progesterone is necessary if you have a uterus. And there are some edge cases where we might want to add progesterone if you've had a hysterectomy. For instance, if your hysterectomy is for endometriosis, progesterone may be beneficial. So there are some occasional reasons to add progesterone, but in general, the vast majority of women who do not have a uterus, who've had a hysterectomy, are much better off with estrogen only.
And our next question tonight comes from Sarah. And Sarah says, I just started the cream and DHEA, and for 4 days, I felt seriously exhausted and tired. And she says, I did stop everything and then suddenly felt so much better. So what could be happening here with the fact that I started, then stopped?
Yeah, I mean, if you take the medication for only a couple days, the medication really hasn't even gotten to a therapeutic level in your system. And so, it's hard to say what was happening and how your body was responding, but you really weren't seeing any of the benefits or any of the real effects of the medications yet. So ultimately, like we talked about earlier with one of those earlier questions, like you need to give it more time. Dr. Green said 3 to 4 weeks really to reach optimal levels in the bloodstream. So, it's something that if you really want to see overall benefits and improvements in your symptoms, you need to give it a little bit more time. And ultimately, our bodies don't do well with like stopping medication, starting back and forth like that. It's going to take your body much longer to acclimate to a new medication, whether hormone or not, if you're not taking it consistently and regularly. So
the body doesn't like change. And, when you start HRT, suddenly the levels of your hormones are going up, which is what we want. But what we really want is to get to that 3 to 4 week point where they're no longer really going up. Now you've got this new, what we call steady state, where you have this new level that's relatively stable. And that's what we're going for. But that transition period where the hormone is changing, sometimes that can actually make symptoms worse. So you got to kind of hang in there for the first few weeks. And sometimes you are going to put up with some actually feeling worse at first, which is frustrating. But it does get better. And starting and stopping it just, makes that even worse. So, you really kind of got to commit to this, give it a real trial, really give it 3 months. But you should start feeling, some benefit probably a month in, and that if it is making you feel worse, that should go away fairly quickly.
Absolutely. And our next question tonight comes from V. And V is wondering, what are some of the potential side effects of HRT that I might experience?
I would say probably the most popular thing we hear from patients when they're starting estrogen therapy is breast tenderness. The breasts tend to respond to that estrogen. They react to it. And so it's often very common. And you may have noticed this early on when you're having regular cycles. A lot of women get breast tenderness in that premenstrual phase of their cycle monthly too. So it's the same phenomenon. So when you first start HRT, the breasts are responding to that. And so that's probably a common complaint I get a lot, when patients are first starting. So we kind of like to give them the anticipation of kind of what to expect. Also, just as you're starting HRT too, the other thing that a lot of patients experience is changes in their GI function and patterns. So you can notice some bloating, maybe some water retention, maybe if you were regular having normal bowel movements every day, that might change slightly, as your body responds to the hormones and how it's affecting your gut too. But every patient's unique. And so ultimately, we don't like to give like a pick list of all the things that can happen, because then I almost feel like patients are looking for them too. I don't know if you feel that way. Like, here's all the potential side effects. And, it's human nature. We see a list of things. We're like, oh, do I have that? Do I have that? We wonder and we question. It's better to just kind of observe yourself and observe how you're feeling and reach out to your doctor who prescribed, so that you can let them know what's going on and ask them if it's normal. So I think that's something to expect.
Yeah, there's this classic thing that every medical student thinks they have whatever disease they're studying. So it's like, as soon as you're aware of something, all of a sudden that's something. Oh my gosh, I think I have that. Mm-hmm. Sometimes it's, we want to give you, an idea of what some of the side effects are, but if we give you an exhaustive list, it sometimes kind of makes that worse.
Yeah, absolutely. Well, and speaking of side effects, this one's not necessarily about HRT, but Kathy is just wondering about menopause in general. And she says, is dry eyes caused by menopause? She says, I've never had dry eyes prior to this, but I'm not sure if it's connected.
It can be, but there can be other sources of dry eye, but it's one of the non-classic symptoms that some patients experience. And some of the other ones we hear about too are like ringing in the ears and vertigo. And sometimes, there's a sensation that some patients will have where they feel like there's something crawling on their skin. That's very, very common as with hormone changes and how the skin responds and the nerves respond. So these are kind of non-classic things that you don't really hear about, like the hot flashes and the night sweats that everyone kind of knows about, and it's been joked about in media and all kinds of stuff. But these other symptoms are kind of insidious and kind of sneaky the way they sneak in, but it can be.
Absolutely. And our next question is from Chandra. And she is wondering, she says, can the cream help increase my libido? And if not that, what might help me?
So the cream, that typically it contains estrogen and progesterone for most patients that have a uterus, it can help. Estrogen can help somewhat, but because ultimately by returning, estrogen to the tissues in your reproductive tract that are responsible, for the sexual function, things like that. It can help your libido overall, but also women can notice an increase in their libido from testosterone. And the way we give testosterone is through a supplement called DHEA, which is a safer, gentler way to raise testosterone very gently, low levels. But ultimately for women, there's so many different factors that go into sex drive and libido. And it's very much, a multidisciplinary and multidimensional approach that we have to take. So I often will ask patients, well, when's the last time you and your partner have checked in on their relationship? Mentally, I think for women, if there's any other things that are not going well, it's really hard to turn your brain off. Things work very differently. And there's so many different things that you can explore. There's, sex therapists out there. There's all kinds of things. The hormones are just one piece of a bigger puzzle. And I think that, there's no instant fix. I think it's important to realize that too.
I think to kind of add on to that, I think that's also a big way that the cream can help with libido, because some of the other symptoms of menopause can really kind of whack. If you're not getting sleep and you're tired all the time, that's going to knock your libido down. Mm-hmm. And so even if it doesn't directly affect the libido, it's going to help these other symptoms, like mood swings and sleep issues and some of these other things, even helping with skin and hair so you look and feel better. And all those things can also help your libido. When you're rested and you feel good about how you look, all those things help increase libido. So even if it's not working directly, it's definitely going to help indirectly in those ways.
Absolutely. And our next question tonight is from Rebecca. And Rebecca says, I'm literally miserable because of hot flashes and trouble sleeping. Will HRT help me with this?
Short answer is yes. It can definitely help with those symptoms for sure. And I think that a lot of our patients, trouble sleeping or trouble staying asleep, waking up several times in the middle of the night, whether it be from night sweats or just not being able to get restful sleep, it's so common. And many of our patients really see that that's one of the first benefits they notice is they start sleeping better. And then the hot flashes will start improving too. So definitely could help.
Absolutely. And our next question comes from Kara. A lot of comments in here. Comes from Diana. And she says, how often should the dosage be adjusted?
Well, really, it's a matter of how your body responds. There is no standard algorithm for when we should adjust dosage. I've had patients recently ask me, well, I'm 55 now. What should we change about my dosage? And my response is always, well, how do you feel? Because that's really how we base what your dosage is and if we need to make adjustments. So if you're doing great, you're feeling well, everything in life is pretty optimal, and there are no concerns about symptoms creeping back in or becoming bothersome to your day-to-day life, there's really no need to mess with success, right? It's not like a certain time period that we need to adjust your dosage or anything like that. It's really about following your symptoms. And this is why it's so important for women to really know their own bodies. Think about keeping a symptom diary and keeping, inventory of what's going on and being aware as an observer of your own body and what's going on and how you're feeling. So if you start to notice symptoms, start kind of taking note of them, whether you jot them on your phone or on a calendar. We have a symptom tracker that's available on our site too, Maddie. I don't know if you've have that link that you might be able to give it to the ladies too. But there's a lot of things that you could do, but I think that's one of the biggest things is just tracking your own symptoms.
Absolutely. Yeah, I can grab that symptom tracker in just a moment. Thanks for mentioning that. Actually, I've got it right here. Let me just go ahead and drop that in the chat. Feel free to check that out, you all. That's a great resource that Dr. Kat mentioned. And it looks like our next question tonight is coming from, from Taffy. And Taffy says, my doctor doesn't want me to do HRT because my tire Cusick score is 32%. She says, I'd really like to use it, though, for symptom relief. If you can't comment on this, I understand. But I thought I'd ask if you thought I could safely use it or what you think it would do to my risk. She says, I'm 56 and barreling towards menopause, but I'm still at least a year out.
So when you talk about scoring systems, there's several different versions out there. Depending on what specialty of medicine you're in is what you typically pick. But it's basically an algorithm where you put in several things about a patient, what their ethnic background is, if they've had first or second degree relatives with breast cancer. It's a way of trying to accumulate a set of risk factors and come up with like a score, for a patient and what their risk is for developing breast cancer. And that's something that, if your doctor is really hell-bent on using something like that and using that as a guide, but, I think you have to look at the big picture. And it sounds like they might not really be, hormone therapy friendly, because we can't live our life thinking about risk. We wouldn't leave our house, right? We wouldn't drive our cars. We wouldn't get in an airplane. There's so many different things bad that can happen to us every day. Now, if you're someone who has significant family history and just the fear of that scares you to death that you're going to be scared every day taking a medication, well, maybe that's something you have to consider. But I think it's a conversation you have to have. And you as the patient, get out a piece of paper, write down pros and cons, think about what symptoms you're having. And you said you're barreling toward menopause. Like how bad is your life and how much are you dealing with? And do you want to feel better? And ultimately you have to make the choice for yourself, whether or not it's worth the risk.
I think unbundling the score and getting down to what's driving that number can be really helpful. Because there are certain things that are more significant than others when it comes to specifically HRT, and no score as an aggregate is going to really unpackage that well enough. So to me, the real question is what's driving that? And it may be something significant, and I may agree with your doctor that, this is really pretty risky for you. Or it may just be a bunch of little small things that don't really add up in a way that would make HRT unsafe for you. So this is something that you can onboard and ask your Winona doctor, and instead of giving them the score, give them the specifics about what's driving that score, because that's going to be much more helpful.
Absolutely. And our next question tonight comes from Amy. And Amy says, I'm getting switched from birth control pills to the progesterone IUD. And she says, will I need to have estriol increased to compensate for getting off birth controls?
So if you're of an age where you're still at the risk of getting pregnant, you still need birth control to prevent pregnancy if you don't want to get pregnant. That really doesn't affect your ability to receive hormone therapy. And for most patients, it's really, again, going back to your symptom profile, if you start to notice more symptoms after you come off of a combination birth control pill. So for the patients who don't know, combination birth control pills have both estrogen and progesterone components, but these are synthetic versions of our hormones that are suppressing your body's ovulation to prevent pregnancy. So if you go to a progesterone-only method of birth control, there's a chance that you could have more symptoms because you're not getting that synthetic estrogen in addition. But it's something that you're going to just have to watch and observe and see how you feel when you make the change. I wouldn't automatically just, there's no way for us to calculate how much more estrogen are you going to need. We need to wait and see how you feel and how your body responds.
Yeah, I've definitely seen it go both ways, where people make that switch from a birth control pill to an IUD, and the HRT is still adequate and working well, and other people, we need to up the dose a little bit. So it really is watch your body, listen to your body, and let your body drive the answer.
Absolutely. And our next question tonight comes from Jennifer. And Jennifer says, what is the recommended form of HRT, if any, for a 48 year after total hysterectomy? I have a family history of breast cancer and my mom, but my doctor is not wanting to start it for me.
So there's no recommended form for every patient, based on your age. I think that, I tend to recommend the transdermal forms of HRT more, just because I feel like, using a transdermal via, meaning that delivery of the medication through the skin, whether it be a cream or a patch, patients tend to tolerate it better than the oral. They tend to get less like GI side effects, stomach upset, indigestion, things like that, than taking pills. But it's really about what fits into your lifestyle the best. That's my opinion. But if you're somebody who's not going to remember to put the cream on, or the patch is going to irritate your skin, maybe you break out from Band-Aids, maybe they're not the best options for you. Maybe the pill is the way to go. So you have to take a look at your life and your lifestyle and figure out what form is going to fit into your life the best.
Absolutely.
And that's why we're here. If your doctor's not willing to help or start, that's why Winona exists.
Absolutely. And it looks like our next question is from Karen. And Karen is wondering, what other supplements or medications contradict HRT? She says like a big no, or some that you might want to talk to your doctor first about.
So there's red flags when I'm reviewing a chart when patients come to us at Winona, because there's certain medical conditions that really make taking hormone replacement therapy very high risk for patients. So if you've had a blood clot in the leg or the lungs and you're on blood thinners, that's a red flag. Then you're not somebody who's really a good candidate for getting hormone therapy via telemedicine, like a platform like ours. But as far as specific medications or supplements, I caution women that are, paying for other forms of estrogen or progesterone that they're buying online. Generally, these things that you can purchase without a prescription are subtherapeutic, or what we call homeopathic, meaning that there's such a low dose of the hormone that it can be given without a prescription from a doctor. But I've had patients taking estrogen and taking other things and taking all kinds of other things out there that have all these different phytoestrogens. And ultimately, when you're starting hormone therapy, you can kind of throw out all that other stuff that you're taking, because it's probably not helping. That's why you end up going on hormone therapy to begin with. But you can stop with those other treatments. The other thing that I see a lot, and I know we talk about it in our group of doctors, we bounce ideas off each other and we help each other and ask clinical questions. But we have a lot of patients coming to us on a supplement called DIM, which is like I don't even remember what it stands for. It's like diindol something. It's supposed to help. What they claim on the bottle of the supplement is it's supposed to help with your estrogen metabolism. So it's
supposed to clear the bad estrogen. That's the part that cracks me up.
Yes. But it's like they sell it, to try to help your symptoms without actually prescribing hormones. But to me, if it's going to modify what your body's doing to estrogen, like why take it when you're actually taking the good estrogen that's supposed to help you? I don't want it to mess up your absorption and how well your body processes the medication. So I usually tell patients to stop that when I see that on their med list.
Yeah, black cohosh is another one that tends not to be helpful and can be really hard on the liver. And there have been some unfortunate cases where people have had some serious liver problems from that one. So that's one I always recommend stopping. Most of the supplements, honestly, are a waste of money, but they're not going to hurt you. So, it's one of those things. If you feel better taking it, knock yourself out, but you can probably save yourself a lot of money by decreasing the amount of supplements you're taking. Sometimes the supplement list that people come in on is staggering. It's like, how do you remember to take all 18 supplements every day? It's like amazing to me. And how can you afford that? So, eventually you're going to get interactions with stuff. So in general, I'm not a big supplement fan. And I think for most people, once they start real HRT, they're going to find that they don't need it. I had a patient this week who told me she was on a progesterone cream, and I asked where she was getting it, and then I looked it up, and it's like, wow, there's so little progesterone in that cream. It's like progesterone in name only. And I looked at how much it was costing her. It's like, I went on the website. I'm like, oh my gosh, look here, I can save you a bunch of money this month.
Oh my goodness.
Wow.
And it looks like our next question tonight is coming from Adrienne. And Adrian says, do you all have any input on how this affects lipidemia?
Lipedema. I don't
How it
really.
affects, sorry, lipids or lymphedema or? Which question is this?
It's lipodema.
I'm not quite sure what she's referring to.
I think is it to do with like cellulite and fat, I think build up is what is
The
being
lymphedema probably. What's the patient's? Oh, here it is. Yeah, I think it's a typo probably. Sorry.
It might be.
It's supposed to be lymphedema.
Yeah.
So if the question is how will it affect your lipids, that's why I'm confused. HRT should, as an aggregate, improve the lipid profile. So it will increase your good cholesterol HDL. It should decrease your bad cholesterol LDL. It can, gosh, I just blanked on it. What's the other one?
Lymphedema? You were thinking?
No. The other cholesterol number that it might increase slightly. Anyway.
Triglycerides?
Yes, triglycerides. Thank you. See, I'm 61. I'm of an age. Anyway, if the question is more swelling and that kind of issue, it may help. It may not. It's not going to specifically target that.
I mean, there is a condition called lipedema, but it's with an E. I don't know if that's what she was trying to say. Like some people can develop abnormal collections of fat, like on the lower legs and, different parts of their body.
Yes.
Kind of like more diffuse collections, we see like things called lipomas, which are like isolated little fatty tumors, but this is like excess fat and abnormal development,
yes.
like in certain part of the body. And I'm not aware that HRT really has a direct effect on that. That's something that we don't really know why some patients are prone to that and some are not.
I do have a patient, incidentally, that has nothing to do with this conversation, that has found improvement with that from a GLP-1. I don't know if that's sort of an across-the-board thing, but at least this one individual told me that her GLP-1 was improving that condition. So something to think about.
There you go. And it looks like our next question is from Rebecca. And Rebecca says, the majority of my hot flashes occur during the day up until around 4 p.m. After that, I don't really have any. Why might that be?
Well, it's hard to say. My first question is, are you taking HRT or not? And then what form are you taking? Sometimes it might have to do with when you're taking your medication and, when the concentration of your symptoms is the worst might be in relation to, when the levels of your hormones are getting lower, far after when you've taken your dose. If you're not on HRT, this could be your own internal fluctuation of your own hormones and how they're released in kind of a pulsatile fashion throughout the day. And so you can have some times of day that are worse than others. So it's hard to know, without knowing more information about the patient specifically, but keep track of that. This is why the symptom diary comes in handy, so that we could see, if you were my patient and turns out you're on treatment, but you're taking it at nighttime, and then, all of a sudden you're getting, more symptoms at a certain time of day, we might adjust, maybe try it during the day. We might, change when you're taking your medication.
Yeah. And I think, this is something that's interesting in medicine, actually, mostly in life in general, is that the why is usually the hardest thing to answer. And it's usually the least important. The exception is if there's something that you can change that's driving it, then the why can be helpful. But usually, why did this happen to me? It's like, why is my body behaving this way? Well, I don't know, but I know how to fix it. And so again, the symptoms, the fact that it's happening is a very important observation. And how to make it go away is something that we can help with and make it and improve it. Why is almost philosophical and a lot harder to answer, quite honestly.
Absolutely. And our next question tonight comes from Lori. Lori says, I have been on my HRT plan for about 3 months and I've noticed some weight gain. Is this normal?
Well, it can be related to the changes in your digestion and then, sometimes those bloating side effects. So some patients may notice, a change in water retention. They might notice, that there's a few extra pounds on the scale. I usually tell patients to stay away from the scale as your body's starting to get adjusted to medication. Typically, for women that are going to get the benefit of having weight loss with HRT, it usually happens later. It's one of the last benefits we really see. And it's important to bring back the fact that like HRT is not a magic bullet. You still have to do the work to take care of your body too. So just taking hormones is not going to keep everything, hunky-dory in your body, I guess. So you still need to eat well. And one of the biggest things I notice for a lot of women in midlife, they don't get enough protein in their diet. And what happens is if you don't get enough protein for your body to use as fuel and to maintain your muscle mass, your body will start accumulating fat because it thinks you're like in starvation mode. So there's a lot of different things that you can do. But I think that, go back to basics and kind of maybe do a nutrition audit and kind of look and see what you're eating. What can you make changes with? How's your activity level? Are you doing weight training or resistance training? Because that's important too, to stay active. So think about all those bigger things.
Absolutely. And it looks like our next question is from Misha. And she says, how can I boost my testosterone for muscle strength, bone strength, and energy?
You could take the DHEA supplement that we recommend. That's a very gentle way to do it. And that's something, that is very well tolerated by most patients. And it's tends to be better tolerated than actually taking testosterone. And the fact is we don't have testosterone supplementation available in the US for women. All the products that are made for men. There's nothing that's, available for women. So this is a way that we can gently increase your testosterone safely.
Absolutely.
There's also strength training, increasing muscle mass, and exercise can also increase your testosterone. So there's some sort of natural ways to do it as well. But the DHEA is very helpful in addition to these other things.
And our next question comes from Kelly. And Kelly says, is dry skin and menopause related? And will this treatment help improve the skin? If not, do you have any recommendations on good skincare products?
Yeah, so skin and hair and nails can be significantly affected by the loss of estrogen too. So, typically, as our estrogen decreases, the skin loses its internal moisture, the normal structure, and when we look at skin and we look at the layers of tissue, it gets thinner, more brittle. The tissue is less elastic, less supple. So typically adding estrogen in will help that. But also hydration, drinking lots and lots of water is really good. I think as a population, we don't drink nearly as much water as we should in America. I think everywhere. But anyway, those are things that you could do. And, there's obviously all kinds of skincare products and things out there. You just have to find something that works for you. But yeah, HRT can help with those skin changes for sure.
And just a shameless plug, we have a wonderful facial cream, an estriol tretinoin facial cream. So at least for the face, we do have something at Winona that's actually works extremely well. So that's a skincare product I would recommend.
Mm-hmm. Absolutely. And our next question tonight is from Karen. And Karen says, I am currently taking DHEA in the bioidentical cream and am having issues with underarm odor starting. Is that normal? I've been on the protocol for 1 month now.
So sometimes as your hormonal environment in your body is changing, you may notice, that your sweating patterns may change, and I've had some patients complain of a change in their body odor. And that's just something, it's like your body is acclimating and it's processing the medication in the different tissues in different ways. I would encourage you to just stick with it, and if you need to, change something you're doing as far as like what deodorant you use or what you shower with, you can play with that to see if it helps, but it generally will get better with time. It's something that some patients will notice.
This goes back to the skin thing too, in that as your skin becomes healthier, there are glands in your skin that can reactivate. that had sort of become old and dried up and no longer working. And as the skin becomes healthier from the HRT, these glands can reactivate. And one of the things that can happen is you can sweat more, and that can change the body odor, but it does tend to level out.
And our next question tonight is from Rebecca. And Rebecca says, do you have any recommendations about at what time of day I should take these medicines? She says morning versus night.
I mean, we have general guidelines, and most patients will start, if they're using the combo cream, will start using it at night. It tends to help with sleep. But really, it's the best time to take it is when you can remember to take it. And so if you are somebody who works nights, and so maybe using medication at night is not so feasible, then maybe you want to do it at a different time of day. The important thing is to be consistent with it. And we do sometimes have to adjust. Like I have had patients that start using DHEA in the morning and do great with it for a couple months, but then all of a sudden they notice some changes, and we sometimes change it to a different time of day, like midday or bedtime. But that's something you'll have the conversation with your doctor, and we can kind of give you some ideas about that too.
And it's okay to experiment with different times of day. As long as you're taking it once a day, it's okay to try and see, hey, how does my body react when I take it in the morning versus night? And everybody's different. And so it's okay to do that and try it out and see what works best for you.
And our next question is from Chandra, and she's wondering, are there any side effects that might come with the DHEA?
Yeah, the most common thing we see is acne for some patients. Also, I've had patients complain of like having a more oily scalp, and it's the same thing as what Dr. Green was just talking about with the glands kind of being more active after you're starting hormone replacement therapy and the DHEA supplement. Sometimes that's part of it. But for a lot of women, it's very distressing, the acne part, because some of us may not have experienced that since high school, and then all of a sudden in midlife, you're going through all these hormonal fluctuations, and then throw on top of it, you get a pimple. It's no fun at all, but it's a temporary thing. Generally, it's just your body adjusting to the medication, and then with time, that'll happen less and less and ultimately go away.
And our next question is from Adriana. And she says, I'm 51 and my estrogen shows high compared to the progesterone in my blood test. She says, I have terrible anxiety, mood swings, and sleep disturbance. I'm having vaginal dryness and pain with sex. Should I just take progesterone due to the higher estrogen, or what would be the best option in my case?
So we've been waiting for this because every webinar that we do, we get questions on lab tests. So this is where we get to talk about the fact that lab tests are just not helpful. And here's a perfect example. In the list of symptoms, having sleep disturbances, mood swings, anxiety, vaginal dryness, to us as the physicians, that is a big red flag. Your estrogen's low. But then you do a blood test, and on this particular day, the level's high. Makes no sense. It's incongruent with what your body's actually experiencing as far as symptoms. This is why lab testing is not necessary to treat you with hormone therapy. It's not needed. Doesn't help us determine what you need. It doesn't help us change your dosages. Really, the symptom profile and that symptom diary is so much more helpful for us to take better care of you.
I would take it a step further in that I think in some ways lab tests are harmful. I can't tell you how many patients we get that have the story that they went to their doctor and they complained of all these symptoms that are just classic screaming, you need estrogen. And they do lab tests, and lab tests came back normal, and their doctor said, oh, there's nothing wrong with you, or put them on an antidepressant or something like that.
Yes.
And then they come to us and it's like, well, forget the lab test, listen to your body. And we put them on HRT and oh my gosh, I feel great. And so, the lab tests really harm that patient. Not to mention the fact that it's a pain in the neck to go to the lab. They're time consuming, they're costly, and you might as well pick a number out of the hat. It just really doesn't give any useful information.
Mm-hmm. And our next question tonight is from Hoda. And Hoda is wondering, do symptoms affect Black women differently, or is it more hereditary?
Well, I think that there's definitely a disparity in care. There is some data out there, and there's not that much in the medical literature, but the stuff that we do see is that sometimes women of color can experience symptoms worse, and they're less likely to get the help that they needed just based on, equity in healthcare and what's available to patients. But more and more data is showing that women of color can have symptoms that are worse. They can have symptoms for a longer period of time. And also, longer period, that they're experiencing that. And sometimes their menopause symptoms can go much later into their 50s too. So they might end up needing care longer. But I think we're still learning about this, and it's something that as we learn about health disparities and we learn about this is something that we're going to get more and more data about, especially as hormone replacement therapy becomes more readily available to patients, we'll get more information about this over time. I think it's cool. I never heard the name Hoda besides the woman who's on like one of the morning shows, right? Wasn't she on the Today Show or something?
Maybe that's our Hoda.
Well, I don't know.
These population-based things are interesting and they're important when we're making population-based decisions. But as we've been sort of hammering in all night, it's really your individual symptoms that's important. So whether, this group of people on average tends to have worse or better is really less important than what are you experiencing, because that's who we're treating. And so to me, that's the really important question is, what symptoms are you having, and let's get these symptoms better.
Yeah, absolutely. And our next question tonight is from Deb. And Deb says, I had a total hysterectomy at 40. I started HRT from my doctor, but now at 52, I have switched to bioidentical from Winona. How long is it reasonable to continue HRT?
It's reasonable to continue as long as it's helping you and you're feeling well and you don't have any medical conditions that make it dangerous. So if you're doing well and your symptoms are well controlled and you really feel like a better version of yourself, there's no reason to stop. But it's something that, whenever you feel ready, we have patients that, just maybe want to dial back on how many medications they're taking as they get older, or, maybe they don't want to stay on something forever. I don't know about a lot of the women listening, but for me, HRT has made such a big difference in my life. I don't really ever want to stop it. I don't want to think back to about like how I felt without it, so it's a personal decision. Like we said before, it's individualized. Every patient has to decide for themselves.
Absolutely. And our next question tonight comes from Jenny. And Jenny is wondering, is there any plan to incorporate testosterone into the Winona program, or can it already be prescribed?
Well, testosterone, because it's not FDA approved for women in the United States, it's not available, and it's actually treated like a controlled substance, like narcotics. And that comes from, it being widely abused, by bodybuilders or by, athletes in the past, taking very high doses of testosterone. However, there was just this big expert panel discussion that happened at the FDA in mid-July. And one of the doctors that was on this panel was really advocating toward that the FDA come up with some guidelines and release some information about products that could be available for women. So right now, because of the laws and regulations around testosterone, you won't see it on a telemedicine platform. Typically, it's something that, you need to be from an in-person provider. But so that's why we use the DHEA, but who knows what the future holds? Maybe if something changes and there's more, information and less regulations on it later, we might be able to.
Let me just say, as far as there are some states that do allow testosterone, I think Florida is one of them. We've decided at Winona to basically, we use the most restrictive rules and use that across the board. We think it's the safest way to do it. Also, there are telehealth companies that sort of bend the rules. They do sort of these funky things. I had a doctor I hired who has just quitting another company, and they were flying her out to different places every 6 months and just having them see all the patients in person so she could write controlled substances.
Wow.
So there are these sort of telehealth workarounds. They're kind of gaming the system. We don't do that at Winona. We do our absolute very best to follow not just the letter of the law, but the spirit of the law as well, and do things well and do things right. I just think it's the right way to do business. So write your congressman, write the FDA, but until it's like really legitimate, that's not just something that we can do.
And for our last question tonight is going to come from Chandra, and she is just wondering, what is the difference between bioidentical hormone and regular HRT?
So the big difference is that it's just the bioidentical is an adjective. And what it means is when you're taking a medication that's bioidentical, it means that structurally, the chemical structure of that medication is identical to what your body makes on its own naturally. Whereas, there are regular HRTs, there are HRTs you can get a prescription from and get from the pharmacy from your in-person doctor that are also bioidentical. We have 3 different types of estrogens in our bodies as female human beings. And so as long as it's one of those types of estrogens, and as long as it's progesterone and not a progestin, which is synthetic forms of progesterone, then it's bioidentical. I think that's a misconception that a lot of women think that if you're getting it from, another source, that it has to be a synthetic, but not always. I mean, a lot of the traditional HRTs that were prescribed years ago were synthetic. And that weren't bioidentical, like Premarin was a really common one, used readily and diversely throughout the country, but it came from the urine of pregnant horses is how they discovered it. It had all these other forms of estrogen that weren't biologically active in human women. And so that was not bioidentical, for example. But if you're taking estradiol or estriol or estrone, then it's bioidentical, and progesterone, not progestin.
The way it works is these hormones sit on something called a receptor, and people talk about a key in a lock. And so the hormones trigger the receptor, and then the receptor triggers the brain, and this causes an effect. And the bioidentical hormone, because it's the exact same hormone your body makes, it fits perfectly into that receptor, and you get the maximum benefit of that hormone receptor interaction. Whereas the synthetic hormones, or the quote biosimilar, are similar but not identical. And so they may trigger some effect on those receptors, but you're not going to get the full effect. And I'm going to tell a story. I haven't told this story in like 3 years because someone told me to stop telling it because women don't like car stories. But I'm going to tell it anyway because I still think it's a good story and it's been a long time. So if you think about a key in a lock, way back in the old days, in college, I had this old beat up Datsun B210. And my best friend, he had a Datsun. This is back in when Nissans were Datsuns. He had a 240Z that was like, all revved up and everything. My B210 key would fit in the door of his 240Z and unlock his door. And so I used to unlock his car door with my B210 key and say, it's a Datsun. But it wasn't good enough to start the engine. So the key was enough to open the door, but it wasn't a perfect match and it wouldn't turn over the engine. And that's kind of how these synthetic hormones work. They're good enough to give some effect, but they don't give the full effect. And that's where the bioidentical hormones give the full effect of the hormone that your body's making. And so that's why we feel that you're much better off with bioidentical hormones, because you get the full effect of the hormone and we think also fewer side effects. All right, sorry, Rob, I told my car story.
I like that. I think it's a good analogy,
Absolutely.
It'll be another 3 years before I say it. Tell it again.
Oh, I love that. Well, I was going to say, Dr. Green, Dr. Brown, thank you so much for giving your time tonight and just answering all of these questions. I know that everyone really loves getting to hear your thoughts and kind of opinions kind of around like what's going on that front. Just for everyone who is on the call tonight, if you didn't get a chance to have your question answered, I know there was a few of you. I'm so sorry we didn't get to your question tonight, but a few places that are great to reach out to. If you're a Winona patient, your Winona doctor is available 24/7 in your patient portal to answer your questions. Please reach out to them. That is a great place to reach out to. We also have a number of resources on our website, like the symptom tracker Dr. Brown mentioned, but we also have a lot of journal articles that talk about all kinds of different symptoms, so you can find a lot of information in there. Another one is we have our podcast, the Menopause Hour. So if you want to listen to more conversations like these or hear some stories from our ambassadors or other women who have had experiences with Winona, that's a great place to listen to that. In the gym, on the way to work, on the way home from work, that's a great place to listen to that. And also, we have lots of these live Q&As and doctor dialogues all the time. So we do these every other week on Thursdays, and we would love for you to join another one. We would love to see your name pop up again. I know sometimes I see lots of repeat people, so I love that. We love new people also jumping on. So lots of different places to get your questions answered as well. But yes, thank you so much, everyone, for being here tonight. Thank you, Dr. Brown. Thank you, Dr. Green. I know that you guys have busy schedules, and I know everyone on the call also has busy schedules. So it's great that we have a place to kind of get together and all kind of talk about this.
And if you learned something tonight, don't gatekeep it. Share it with your girlfriends. Talk to other women about this, because I think that the big thing is just getting the word out. Education's available. There's information out there that can help you. So, yeah.
Awesome. Well, like Dr. Brown said, don't gatekeep, share the information. I feel like that's a great goal to end the night on. So we will end there. And thank you so much, everyone, for being here tonight. I hope everyone has a great rest of their night.
Thank you.
And we'll catch you all next time.
All right. Have a good night, everyone.
Bye, guys.
Thank you for joining the Menopause Hour, brought to you by Winona. Menopause care made easy. To learn more, find Winona at bywinona.com and on Instagram at bywinona. Want to have your questions answered next? Register for our upcoming live Q&A, linked in the show notes.